Okay. Thank you all for attending. I would like to thank my teachers for providing this opportunity to be with you today. And thanks to my colleague, radiologist and radiologist registrars for being here. As we've done last time, we will show some cases. And it's not all about the diagnosis, but mainly it's about highlighting main concepts regarding each case. So please, doctor, have a look at this CT scan, and I'll give you some information regarding the patient.
No.
Is a 53-year-old female patient, has a few days of epigastric pain.
No.
There are other information related to history, but if I give it to you, it is enough for diagnosis, even without radiology, actually. And the main problem is here.
No.
Can start describing. Let me know if you need anything.
نعم صح. Axial section, contrast enhanced CT scan, showing that this is a portal face.
Which phase of enhancement?
Portal face.
Yes.
نعم. Showing يعني enlarged, heterogeneously enhancing, I think it's pancreas, with multiple area of non-enhancing area.
Yes.
I شفت طبعا bilateral pleural effusion موجود, and pericholecystic and periportal edema in the liver.
Okay, you said periportal edema. Pericholecystic, is that edema or that fluid?
Pericholecystic fluid, sorry. Yes,
Yeah,
sorry,
there's a clear fluid, and also
fluid, نعم.
around the liver. Also paracolic gutters.
Paracolic gutters, yes, right.
And also I'll have a look at the
pelvic region. نعم.
Pelvic fluid, yes. So and you said the periportal edema.
Sorry, I think here is the periportal edema, little bit.
How do you differentiate between periportal edema and intrahepatic biliary dilatation?
Intrahepatic biliary dilatation يعني continuous to the periphery of the liver.
Okay, follow this.
Yes.
Obviously, we have multiple hypodense focal lesions.
Yes, multiple scattered through the liver. Yes.
Yeah.
On the right.
So now, yeah. So what do you think? Is it mild intrahepatic biliary dilatation or periportal edema?
No, I think it's dilatation.
Yes. Why?
يعني away from the portal radicals. يعني شوفها مو يعني not surrounding. عادة periportal edema central يعني الportal hepatis around the central portal.
Yes, if it is obviously we would follow the anatomy of the biliary tract, so biliary radicals, right? Follow them to the center. Biliary dilatation is on one side of the portal vein.
نعم.
Periportal edema is on the two sides.
Both sides. Yes.
Because we said periportal, it is around the portal vein,
around
both sides. And since we are cutting axially, so we said on two sides, on either side of the vein. But the biliary duct is one duct along the vein going on one side.
Yes.
And we follow the you know the anatomy obviously, and we can see that there is mild dilatation. Okay. So let me know if you identified other findings.
يعني I think the main complaint يعني related to the pancreas with the يعني fluid throughout the body from left pleural effusion, bilateral pleural effusion, ascites, pelvic and paracolic gutters, and pericholecystic fluid collection.
Okay, what's your diagnosis?
I think it is an acute necrotizing pancreatitis.
That's perfect. Good. The points we want to highlight here are first, do we need CT always to diagnose pancreatitis, acute pancreatitis?
الCT for يعني severity index يعني to assess the
Yes.
severity. Yes.
Yes, and mainly we can reach the diagnosis if the patient has typical presentation.
Presentation plus
back.
lab study
Yes.
and ultrasound.
Exactly. Worse on supine position, high lipase and amylase.
No.
But we look after a few days of presentation to the pancreas to differentiate between the two types of acute pancreatitis, right?
Yeah.
To see if there is necrosis or there is no necrosis. After 3 days, mainly at 1 week, because at this stage, as for the patient here, we can differentiate between non-enhancing pancreatic tissue and the edema that might be present in acute edematous interstitial pancreatitis. So in this case, we have necrosis, right?
Yes.
Okay. So what do you have any idea about how to state the severity of the acute process? Yes.
يعني نعتمد على الCT severity index. ناخذ يعني هو يعطوها يعني 2 score. إذا النكروسيس below 30% يعطوها 2 score. From 30 to 50% 4 score. More than 50% يعطوه 6 score. بالإضافة إلى البالثازار سكور يعتمد يعني على الاسوشيتد سيمبتومز الموجودة وياه. يعني النورمال يعطوه 0. أكو peripancreatic inflammatory changes and peripancreatic fluid collection on one side or يعني both sides of the pancreas. هاي كلها تاخذ على 1 score. فالماكسيمم سكورز بالسيفيريتي اندكس يصير 10. يعني more than 7 يعتبر severe severity index يعني with high mortality rate.
Great, perfect. So yes, between 0 and 3 points, that's mild. Between 4 and 6 points, that's moderate.
Moderate and 7 and more.
That's severe.
Severe, yes.
So in this case, we have a necrosis. Yeah. Involving most of the pancreas.
Most of the pancreas, yes.
Yes, and definitely this is a case of severe acute.
Severe pancreatitis. Necrotic pancreatitis. No.
For each scan, we need to know, generally, we need to familiarize ourselves to analyze the scan in a way that we could identify for each process, we identify the causes, the complications or consequences, and the concomitant or associated findings. So 3 C's. First C is the cause. First C is the second C, complication. Third C is the concomitant finding.
Cause.
So for a case of acute pancreatitis, regarding the cause,
yes.
What do you see here on the scan? Can you identify a cause? Or at least we put in the report, we describe the findings relating to the cause. Sometimes definitely we wouldn't be able to identify a cause, but putting that in our mind, we can focus on it while analyzing the scan and mention something about it in the report. What's the most common cause or 2 most common causes of acute pancreatitis?
استاذ alcoholic pancreatitis والكولوديكولوثياسيس يعني bile stones.
Exactly. So regarding the gallbladder, do we see any stones?
No.
Okay, and we follow
just distended gallbladder and
we follow the biliary tree. There is mild dilatation. We follow the
mild dilatation
duct. This common bile duct. Can you see it? And we go down, and it is collapsed here, compressed by the inflammatory process. And the distal part, we don't see any definite stone or inside. So we mentioned that in the report. Regarding alcoholism or alcohol abuse, what could be a hint in this scan?
fatty liver يعني ممكن إذا يعني
yes.
إذا chronic. نعم.
Yeah, we don't see any obvious steatosis here. And another thing, if the patient had in the pancreas itself, if part of the pancreas is visible and seen, we can see a hint also regarding alcoholic intake, which is?
Actually, I don't know.
No problem. If the patient has chronic pancreatitis, or the repeated bouts of acute pancreatitis due to alcoholism, and with time,
calcification could be chronic.
Exactly. So if the part of the pancreas is seen with atrophy, calcification, irregular duct dilatation with
dilatation, yes.
We see signs of chronic pancreatitis possible related, and if you have, of course, information from the history. So yeah, for the history, also the patient has high raised white PC count, increased CRP, and high amylase, definitely. Now, these are the causes. Let's talk about the complications. First complication, we have it here, which is the necrosis. Okay. What other complications related to the acute pancreatitis process?
يعني could be this يعني inflammatory process adjacent to the bowel could small bowel obstruction because the duodenum is related closely related to the pancreas.
Okay, let's take them one by one. Necrosis, if there is hemorrhage, if there is peripancreatic fluid collection. Here we have fluid, definitely. And in the case of necrotizing pancreatitis, we call it acute necrotic collection, right?
Right.
When would we call it walled-off necrosis? After what period of time?
after 1 month يصير distended fluid 4 weeks. Yes, 1 month distended the pancreas fluid filled.
True. And if it is acute interstitial edematous pancreatitis, we call the collection acute peripancreatic fluid
collection. Yes.
And after 4 weeks, if it's there and organized,
pseudocyst, pancreatic pseudocyst.
Okay, this is the first thing regarding complication.
No.
Most very important complication related to pancreas
is the vascular state.
Exactly.
Vessels, superior mesenteric artery, thrombosis.
Yes. So now we can see here the splenic artery.
Yes.
Going hepatic, going down superior mesenteric. What are we looking for?
I started looking for vascular complication, thrombosis.
Most feared complication is when it comes to the arteries.
Yes.
Hemorrhage or pseudoaneurysm.
No.
There is active extravasation, definitely that's an emergency. If there is pseudoaneurysm, that's important. The thrombosis is important for the veins, right?
Yeah, sorry, for
more
veins.
common happening in the veins.
Yes. So, the artery pseudoaneurysm and veins.
Yes. So we'll look at the portal and splenic vein, the confluence. There's compression here at the region of the confluence.
Yes.
Through the inflammatory process, but do you see a clear filling defect?
No clear filling defect or pseudoaneurysm.
Okay, that's good. So we finished the fluid collection, the necrosis, fluid collection, vascular. And by the way, if there is an abscess, especially after a period of time, if there are gas locules, we can say that developing abscess. But otherwise, we wouldn't be able to diagnose abscess unless we aspirate and do analysis regarding microbiology. So yeah, other complications now in the vicinity of the pancreas, surrounding the pancreas.
Something about fat surrounding, very.
Yes, look at the
small bowel mesentery.
You're right. Look at the posterior wall of the stomach. The process is filling the lesser sac. And what do you think of the posterior wall of the stomach here? It's inflamed, right?
Yes.
And also
thickened down. Yes.
Exactly, and also the duodenum, obviously, right? And also we look if there is also a colitis at the same time. So inflammation of the surrounding bowel. And superiorly, as you clearly mentioned, we have pleural effusions. and with consolidation and collapse.
Collapse, yes.
In both lungs. These are also the complications. So we covered the complications here. I will show you the next scan. This one is done 2 weeks after the first one. And look at the changes here.
Yes.
I might like put them together. Okay. Let me know the changes that happened to the process here.
يعني أستاذ increasing necrosis will increasing يعني وكأنه صار wall of pancreas necrosis يعني.
Exactly.
Yeah.
There is wall of necrosis, although a little
Yes.
bit earlier, only 2 weeks, but because the process is severe, usually like we call it after 4 weeks, but now
Yes.
it's obviously walled of necrosis.
Necrosis, yes.
Enhancing wall and fluid replacing the pancreatic tissue here. So that's walled of necrosis. What to do now?
أستاذ يعني قصدك المانجمنت؟
Yes.
يعني أستاذ هذا ديت تشو يعني ما يعني شلون نقول يعني not viable tissue. I think you have to remove يعني. بصراحة يعني التريتمنت مو كلش ببالي يعني.
No problem. So would you do surgery or would you drain the fluid?
لا أستاذ بالبداية إذا walled off لازم يسوي له يعني percutaneous drainage قبل I think drainage يسوي له.
Right, drainage. Any other type of drainage? I'll show you this scan now.
يعني إذا مثل طريقة السيدوسيست أستاذ ممكن يسوي لها connection with posterior wall مال الستومك.
Yeah, it's the same principle, same thing.
Yes, yeah, same thing for wall of necrosis. Yeah. Hey, so it's the connection with the posterior wall of the stomach.
Yeah, what do you see in this new scan? This is done after, I think, 6 weeks. Yeah. So what do you see now? What happened to the walled off necrosis?
Yeah, it drained. So.
Okay, through
collection through the stomach. يعني catheter فاتحة على الstomach posterior wall.
Yes. Do you know the name of this device?
بصراحة.
This device called Axios stent. Axios is AXIOS.
Axios stent, no.
Axios, yeah, Axios stent. It's introduced endoscopically and removed also endoscopically. It can stay up to 60 days, and it is used to drain transgastric drainage of pancreatic pseudocyst or pancreatic walled off necrosis. It also can be used to drain the gallbladder for patients who cannot tolerate surgery, who cannot tolerate cholecystostomy, so they can also use that. So the whole, we can see that this is successful, and the drainage also, there's no further drainable collection here. And also, if you look at the liver, there is still intrahepatic biliary dilatation. And look at the common bile duct. It is dilated here and then compressed down. There's no clear stone or anything, but it's compressed because of the inflammatory process. And the gallbladder is still there. We don't see any stone. So we wanted to review the process of acute pancreatitis causes, complications, and management. Thank you so much, Doctor. That was brilliant.
Thank you. Thank you, sir.
شكرا دكتور عبد الله، عاشت ايدك.
العفو أستاذ.
Yeah, we have 4 cases today, so we can move to the second case.
دكتور حسين عبد الكريم.
السلام عليكم أستاذ.
عليكم السلام. حتى تعلق لنا بابا على الكيس.
So this patient is a 54-year-old female who was presented with, sure, this one, presented with periumbilical lumps, and she has left-sided abdominal pain and change in bowel habits. So this CT was done for her, and I'll go slowly from cranial to caudal, and let me know if you see anything.
Okay.
Be guided by the complaint. She said he has periumbilical lumps. She feels some masses or lumps. So we start from there and see what we can find in the CT. Just the umbilicus here.
Regarding the umbilicus, we can see anterior abdominal wall defect with the with the sac contain with omentum content sac regarding the umbilical, and start in the right side pain. بس شوي شوف.
Yeah, so what's the description, diagnosis of this lesion here?
Umbilical hernia.
Yeah, it is umbilical hernia containing omental fat. Does it contain any bowel?
There is no any bowel, no any fat trending.
Exactly. This is very important. There's bowel and there's incarceration, strangulation. That's definitely will be important. But here we can see only fat, and even the fat itself, there is no much like fluid in it or signs of inflammation or anything. So that's umbilical or umbilical hernia. That's done. Now, I want you to look in the upper abdomen and let me know here in this picture if there's any abnormality.
In this section of CT scan, you can see enlargement of the liver with the mild decrease of density, possibly due to fatty liver.
Yes, there's hepatic steatosis here. Now, here, what's the abnormality elsewhere in the abdomen? Do you see a lesion here?
Yeah, the left adrenal, we can see hypotension. Sorry.
Yes. So left adrenal is thickened.
Left adrenal, we can see hypotense area, like.
Yes. What type of density?
It is fatty density.
Yes. So do you think this lesion is causing trouble to the patient?
No.
What's this lesion?
This lesion mostly myelolipoma.
Yes, so that's myelolipoma, usually incidental. It's rounded, fat density, no problem. And the left adrenal is diffusely thickened. So we identified myelolipoma, hepatic steatosis, umbilical hernia. Still, there's another finding. So I want you to just go systematically, look at the organs, and let me know if you find anything.
Yes. Regarding the liver, it's large and there is no focal lesion. Regarding the pancreas, so this strip, we get the pancreas normal in size, no focal lesion. Also the spleen. There's no focal lesion.
So that's it. You write your report and leave it at this. You didn't mention other organs, actually.
Yeah, regarding the vessel, we can see any following defect. Both the kidney is normal size, no dilatation.
Yes.
Pelvic system.
Obviously, yeah, there's no hydronephrosis, no obstructing stone.
ساد الكومبلين مالتها قلت لي right iliac fossa.
No, it's the left side.
Left side, left.
The left iliac fossa and left upper quadrant pain.
ممكن ساد نمشي ويا البول. سيجمويد.
Look at the kidneys.
Yeah. So.
Delete this guy. Well, you mentioned that no hydronephrosis, no stones, but are there any focal lesions?
There is well-defined left kidney. There is well-defined enhanced this lesion in this section. There is well-defined mildly enhanced lesion. I want to compare with native to see the part of the type of enhancement seen in middle
we don't have yes, we don't have non-enhanced scan for this patient, but you would go and check previous studies, right?
Yeah.
So this previous study obviously is here because there is not a hernia here. If you compare the liver before we change the appearance, but there was no obvious steatosis. Myelolipoma is there and everything, but in the kidney
there is well defined mildly or non-enhanced the area.
This lesion wasn't quite obvious, it was probably there at least grossly.
Yeah.
There. So this is the lesion, focal lesion in the kidney now.
The lesion in the left kidney.
Yeah. So what do you think of this lesion?
I think this lesion on top of differential diagnosis, I put the mass lesion or RCC mass or renal cell carcinoma. After compare the contrast. Yes,
it is heterogeneously enhancing, less than renal parenchyma, suspicious for renal cell carcinoma. So when you suspect a lesion like this, what I want you to focus on is how to go from here. Like, let's assume that this is, of course, this is suspicion. There's suspicious for RCC. So what do you do else? Where do you look in the scan? How do you further analyze the scan?
I want to look to adjust to the regional lymph node, and yes. I want to look for the vessel, mostly the renal vein.
Yes.
I want to look for sign for secondaries like renal chest and.
I can tell you there's no bone metastases, and we can also look at the.
I want to see other kidney and I want to see the urinary bladder.
No lesion in the bladder, no lesion in the contralateral kidney, no vascular invasion, no metastasis in the liver or lung bones. So regarding the lesion itself, we need to measure the size and see if the lesion is within the kidney or outside the kidney, because that differs in the staging. For the staging, you don't have to memorize everything, but you need to know where to look and what to report. So regarding the lesion, you measure it. This lesion is like less than 4 centimeters and still within the kidney. If it goes outside the kidney, will that change the staging?
Look the perinephric fat and
Yes.
involve the adrenal gland or extend
Yes,
more than
if it extends to the perinephric region or involves the pelvic LCL system or renal sinus or the segmental veins, that will be T3. But if it goes beyond the gyrotous fascia or involves the adrenal, that's T4, right?
Yeah.
And if it involves the adrenal without direct extension, that will be a metastasis. And also for T3, we need to see involvement of the renal vein and inferior vena cava, whether it is infradiaphragmatic or supradiaphragmatic, or involvement of the wall of the inferior vena cava to differentiate between T3A, B, and C, and the lymph nodes. So for the lymph nodes, do you have any suspicion of an involved lymph node?
If there is regional lymph node
Where?
around perirenal, or if there is periaortic lymph node.
Yes, this one, it is borderline size, barely, I mean, it could be like 9, 10 millimeters, short axis, which is important. Compared to the previous one here, it was slightly smaller with more prominent fatty hilum. This could be involved, could be not. So for this lesion, it is T1A and 0/1 because we are not sure of this one, but definitely it is suspicious and there is no metastasis. That's M0. So you write this in the report, you mention all the findings, and what do you mention in your recommendation?
In my recommendation,
yeah, you mentioned lesion, you mentioned the other findings, and lesion suspicious for RCC in the left kidney, provisional staging, you mentioned that. I recommend
for management stuff يعني.
No, what do you refer to the patient? For example, this was sent to you from general surgery or sent to you from the general practitioner or from another doctor because the patient has vague symptoms. So we identified an RCC. Where do you refer?
Refer the patient for urology.
Exactly. Yeah. So referral to urology and for discussion at urology MDT, multidisciplinary team meeting for renal cancer. So these are the points you want to mention. The point I want to stress here for this patient is the comparison with the previous studies. Always we should look for this. And for staging, for each cancer, we don't have to memorize everything, but we need to focus on the most important points, where to look and how to report them. And for most common cancers like lung, breast, other renal or liver, try to have a good idea about staging and what to report. And of course, the referral, when you see any relevant abnormality related to a certain discipline, you would definitely refer that and for discussion at the MDT meeting. Thank you so much, Doctor. That was excellent.
شكرا دكتور حسين.
Now let's go to our third case.
دكتورة ربا الإسلام.
نعم أستاذ، صباح الخير.
صباح الخير، حتى تعلقي لنا بنتي عليه.
So, doctor, this is a patient, the patient is 65-year-old male patient, presented with a few days of recurrent vomiting and not being able to pass stool. The patient has a previous history, and I will tell you this is a complex case, but I will not give you any further information right now. So have a look. The patient is having recurrent vomiting. This is very important. And have a look at this scan and let me know what you can see here. Now we can start.
Yes. يعني this is over distended stomach.
Yeah, that's right.
And يعني thickness of first part of thickening بال يعني first part of duodenum.
Yeah, what about the second part of duodenum?
يعني also there is thickening.
What about the third part of duodenum?
Third part
Do you see the third part of duodenum? And do you see the second part of duodenum?
يعني first and second looks thickened. The third part really I don't see abnormality.
Okay. Is there any gallbladder here?
I don't see it.
Okay. Look, if you look at other organs, have a quick scan, see if the other organs are missing.
يعني liver looks normal.
Okay.
Spleen.
Yeah. So I'll tell you, there is no second part of duodenum, not even the first part, actually. And there's no third part of duodenum. There's no gallbladder.
And
And
history of surgery?
yes, yes. What other organ is not completely present here?
A pancreas.
Yes. You don't see the proximal pancreas. You don't see, do you see the head of pancreas, neck of pancreas? You don't see it. This is, so see the portal vein to the confluence? At the confluence, you expect to see the neck of pancreas, right?
Yes, and
The body, but there's nothing there. And there are surgical clips here, so there's surgery. Can you identify the type of surgery done for this patient? We mentioned all the elements. We mentioned there's no duodenum, first, second, third, there's no gallbladder. The pancreas, most of it is not here.
يعني CA pancreas removed duodenum and يعني Whipple.
Yes, that's Whipple procedure. Excellent. The patient had Whipple procedure for pancreatic cancer. So I didn't give you the information because I wanted you to review the anatomy, what you see. Sometimes because they don't give you that in history. Either you have to identify it yourself and look to the patient records, go back to previous scans, of course, and see what happened. But here, I wanted to highlight the components of a Whipple procedure. So we remove its partial pancreatic duodenectomy. So what happens here, you can identify 4 parts. First, see the stomach here. The stomach goes here and continues to this part. And there's a problem here. And then goes down with a small bowel. So that's gastrojejunostomy. That's one component. The gallbladder is not here. Cholecystectomy, that's number 2. Number 3, look here. Look at the biliary radicals, biliary ducts falling here to this bowel and going down. That's hepatojejunostomy. Okay, so that's the 3rd component. And the 4th component is what to do with the rest of the pancreas. Do you see pancreatic tissue here?
يعني ممكن التيل بس دكتور يعني نهاية نشوفه.
This image.
This أعتقد يعني I think أكو بالتيل pancreatic tail pancreatic tissue هذا.
Yes, I'll show you corona. This is pancreas.
Yes.
This is the cell pancreas. And it is directly related to the stomach here. And if we go back to the axial, so they either do pancreaticojejunostomy or pancreaticogastrostomy, so that they link the remaining pancreas with the bowel. So we have 4 components now: gastrojejunostomy, hepaticojejunostomy, pancreaticogastrostomy, and cholecystectomy. Whipple's procedure. Now, after Whipple's procedure, what's happening to the patient? Is he completely treated? What's going on here in this area?
يعني narrowing يعني first part إنه first part of the narrowing.
These lesions. We agreed that we removed duodenum, most of it.
Okay.
These lesions around the vessels, what are they?
يعني ممكن تكون recurrence or lymph nodes.
Yeah, they are lymph nodes. Definitely there is recurrence. The lymph nodes are enlarging here.
يعني surrounding
Exactly. Yes.
increase vessels.
Now, so the patient had these lymph nodes. There is recurrence of the malignant process. In addition to that, the patient had repeated vomiting. So what's the reason? What's the cause of repeated vomiting here?
يعني
I'll show you previous.
يعني I think ال over distension هذا مال stomach يعني gastric outlet obstruction.
Yes, look at this one. This one done before. And this one, put it on here. Yeah, obviously there is gastric outlet obstruction. And that's why the patient.
يعني هو cause of vomiting gastric outlet obstruction.
Yes. Okay. Now look at the previous one and tell me what's the reason. What caused that? Look here at this image. And look here. So there is a recurrence of the malignant process evidenced by the lymphadenopathy. In addition to that, what other manifestation of recurrence we can see here?
يعني بالabdominal wall أكو يعني
Yes.
abnormal
yeah,
mass
exactly.
at the central abdominal wall.
It's growing. Yes, there's enhancing lobulated lesion in the anterior abdominal wall, also inside the abdomen here. And it's affecting this area here at the site of gastrojejunostomy. And definitely when we compare, so these are lymph nodes here, we saw that it wasn't that big on this previous scan, but it's now definitely growing. There's no doubt about it, and also extending inferiorly. So there's metastasis here, the anterior abdominal wall, and also inside the abdomen, affecting the gastrojejunostomy and causing this gastric outlet obstruction. So what will be the management for this patient?
يعني بصراحة أستاذ ما كلش عندي فكرة، بس يعني ممكن يبدون وياه كيمو مثلا، أو وبعدين إنه to reduce the size of lesion.
First thing you recommend, because there's repeated vomiting and there's obvious gastric distension, just to relieve.
ممكن يعني decompression.
Yes,
يعني NG tube.
Exactly. So the patient had nasogastric tube, and for this case specifically nasojejunal tube, and just because you need to bypass the narrowing, right? Go through this. So for decompression you can do nasogastric, obviously, but for relieving the obstruction first, nasojejunal tube, and there's a possibility for stenting, right? can stent the lesion to relieve this malignant obstruction. And so thank you so much, doctor. That was excellent. I presented this case just to emphasize the need to be able to identify post-surgical appearance and try. Sometimes it's not that easy, but you do your best looking at the scans, looking at the provided information to you in the history, and also previous scans and patient record to know what kind of surgery, because without that, you won't be able to identify any complications or to follow the whole story and come up with the right conclusions. Thank you so
شكرا
much.
دكتورة ربا. شكرا دكتور حمد. بس I have a question about the gastric dilatation.
Yes.
يعني why not is it stomal obstruction, gastrojejunostomy, rather than secondary to the recurrence of the tumor? Or
Exactly, sir. I agree with you. There is the obstruction is at the level of gastrojejunostomy, but there is this lesion is right at the site, and there is thickening in the wall here. And this could be, if not mechanically causing the obstruction totally, because there's still some fluid passing, it could be functional. If the involvement of the wall of the jejunum or distal stomach, paralyzing the veins, could be like functional paralysis because of the invasion of the wall and nerves there. So that could be one reason, in addition to mechanical pressure from the tumor.
شكرا.
Yes, yeah, definitely. Of course, we expect always that there is a narrowing at the site of anastomosis. That's number one, as you mentioned, sir. And in addition to that, we can see the metastatic process here involving the area. And when this patient also had nasojejunal tube, but they didn't continue with stenting because, for fear of migration of the stent. And at the same time, there's it was not, they thought, let's start with NJ tube and then see if we needed that, because also it is not the best case for stenting for this patient. So I followed this patient. They have the NJ tube done for him. So that's it for this case. It's always good to have discussions about these complex cases, because through this we can always navigate our way through, the surprises that we meet in everyday reporting. I have my final case now.
دكتورة زهراء عبد الحسين.
نعم أستاذ، صباح الخير.
صباح الخير. حتى تعلقي لنا بنتي على الكيس.
نعم.
So, doctor, this patient is a 58-year-old male patient presented with 1 week history of right loin to groin pain, worsened today.
Yes.
What kind of a CT scan is this?
نعم أستاذ، هسه عندنا أكزيال CT scan native study.
Yes.
هو الهيستوري right groin pain.
Yeah, right loin to groin pain for 1 week, and it's patient having more pain today, so that's why he presented, and this scan was done for him.
It's about the major organ, liver يعني ما داش focal lesion, السبلين.
So for this kind, for the clinical presentation, first organ you need to look at is
kidney. Yes.
okay, good. To keep that in mind to answer the clinical question first, and then look at everything. Of course, we need to scan it, analyze everything. But since it's loin to groin, and this is especially, you know, see the patient how he's lying. I had to flip 180
Brawn.
degrees.
Brawn.
Yeah, exactly, because this is a CTKUB, CT renal and urinary, to see if there is any. Stones or obstruction, right?
Yes. بس خلينا نشوف الرايت كدني نرجع عليها.
Okay. Kidneys.
كدني يعني ما دا أشوف ستون يعني بيها بس أعتقد أكو فد mild hydron ستون yes بالميد كاليكس yes.
Very tiny is
Very
stone.
tiny stone yes.
Yeah, it's interpole. It's not it's upper pole. It's not non-obstructing tiny stone, right?
Yes.
Okay.
Bladder.
Do you see any hydronephrosis?
No, there's no hydronephrosis.
Look at the ureters. Follow the ureters. You can follow them from down also. So I can tell you there's no obstructing stone.
No, no
hydronephrosis.
hydronephrosis. اللي UB بس نرجع عليها. Bladder.
Bladder is clear.
يعني clear, distended well. No vesicular يعني junction stone.
Yes. I apologize, I'm not looking at the chat. I see there are some messages, but sorry, I missed looking at it. Anyway, yeah, so now we we looked at the kidneys, ureters, and bladder. There's no obstructing stone, no dilatation, and no abnormality related to the urinary system. So we need to look at other structures, right? So obviously we have a system to look at the solid organs.
Yes.
Tell me, describe what's your system looking at the
liver يعني normal size, no focal lesion seen.
yes.
أصوات السبلين normal size, no focal lesion.
Mm-hmm.
kidney مثل ما قلنا هي normal size, no hydronephrosis.
Mm-hmm. Adrenals are good. Pancreas.
Regarding the pancreas, normal, no focal lesion.
Okay.
بس أكو شفنا فد fat stranding يعني
Where?
أعتقد أكو أورتك شفت أكو فد fat stranding بس إذا أقدر أعيد يعني
Yes.
هنا أنا أعتقد هنا
Mm-hmm.
هذا section.
Yes, yes. Okay,
هنا
fat stranding. Yeah, prior to the fat stranding, yes.
fat stranding aortic, yes.
So what could that lead you to? What's next? I mean, what
contrast.
do you conclude from this?
أكو همات فد أكو يعني همات aortic lymph nodes يعني.
Exactly, there are small prominent lymph nodes, you're right. That's important.
شوف contrast.
Okay, so you recommend, you report this native study, and you recommend a CT with contrast. Based on what? You say I suspect what?
يعني بس على مود نتأكد عن الليف نود وهذا الستراندنج، نشوف إذا أكو فد يعني
What's your
another lesion
differential right now before the contrast? What's your
على
differential?
مود الفيزلز نشوف.
Yeah, you're right. What's the possibility?
يعني باسكولاتس مثلا نفكر إذا هيك يعني ستراندنج وأكو ليف نود برأورتك، فكر مثلا بالباسكولاتس أو
Yes, that's possible. Yeah.
yes.
Other possibility?
يعني إذا أكو هو بس الإيج مالته إيش قد دكتور؟
58.
yes. مثلا نفكر بأنيوريزم، مثلا إذا أكو أورتك أنيوريزم.
You're right.
yes.
What do you think of the diameter of the aorta in this region?
يعني هنا اللارج بنفكر مثلا ممكن إذا هيك برا أورتك يعني أكو ستراندنج وليف نود واللارج أيورت بنفكر بالمايكوتيك أنيوريزم.
Okay, good. What's the normal diameter of the abdominal aorta?
يعني هو الأبر ليميت يعني 25 ملم.
Yeah, it is. You're right. It's between 25 in the upper part of the abdominal aorta. The bifurcation is 15 millimeters, 1.5 centimeters. It's between these numbers, and of course between 25 and 30, that's ectasia, and after that you go to aneurysm. So there's focal dilatation of the infrarenal abdominal aorta, right? Surrounded by fat stranding and prominent retroperitoneal lymph nodes, periaortic, para-aortic here. Okay. So you recommend
for contrast.
What's specific contrast CT you say?
Arterial.
Okay, CT aortogram, right?
CT angiogram. Yes.
Yeah. CT angiogram of the aorta or CT aortogram. I'll show you this one. No.
هنا بهذا السكشن.
Yes.
يعني تقريبا هذا level of renal artery، ممكن هو الكوز مال loin vein يعني إذا يستند الرينال.
Yeah, it's below the level of renal arteries. Yeah.
Yes.
What additional findings provided by the
عندنا يعني saccular dilatation of abdominal aortic، يعني هو possible of aneurysm. وعندنا هو يعني surrounding by peri-aortic stranding.
not only stranding.
Possible of mycotic. Yes.
There's a
أكو
fluid
intramural hematome يعني mural
with
thrombus.
enhanced material at the border. Yeah, it is.
mural
I
thrombus.
think part of the
ما
inflammatory
عندنا
process.
يعني ما عندنا leaking يعني peri-aortic leaking. ألسر أكو small ulcer تاشو هنا بهذا section.
Show the previous one. The calcification here was there.
Yes.
And the patient didn't have, looking at the vessels in general, the aorta and its branches, you don't see a lot.
Yes. يعني عندنا celiac with supramesenteric
me?
artery يعني good contrast following، يعني ما عندنا شيء بيهم، بس أعتقد بس أشوف الرينال artery يعني إذا أكون extended إلى left renal artery okay بس الرايت
No obvious significant atherosclerotic process. That's my point, right?
yes يعني بس small foci ما calcification شفناها
Yeah,
يعني
and into
no
the
significant about
the
يعني age مالته it's okay.
Okay, so there is a saccular outpouching.
Saccular outpouching of abdominal aorta يعني infrarenal level
Surrounded with fluid,
surrounded by
lymph nodes.
fast surrounding and lymph nodes يعني possible of mycotic aneurysm.
Okay, that's great, excellent. So it's not, first we said there's a possibility for atherosclerotic penetrating ulcer, but the patient doesn't have any significant atherosclerotic process looking at both scans. And the findings of fat stranding, fluid, and lymph nodes also go with mycotic aneurysm, right?
Yes.
What do you look in the
shape my
history?
aneurysm saccular يعني كان مو
Exactly.
fusiform
Very
plain
important. Yeah, true. Because saccular, which is eccentric, it's different than fusiform, which is the concentric that goes with the atherosclerotic process. Saccular is more with mycotic, with other features we describe. What category of patients are more amenable or vulnerable to develop mycotic aneurysm?
يعني diabetic
What do you expect the patient to have normal immune system or have other?
يعني immune compromised diabetic patient.
How do you get mycotic aneurysm? Yes, you get it from bacteremia, septicemia, spread of infection. So the patient either immunosuppressed, IV drug abuse.
Infection, yes, hematogenous
Yeah,
يعني.
exactly, having infective endocarditis with showering of emboli, septic emboli, right?
Yes.
And in general, weakened immune system. For this patient, we checked the history. The patient had poor dental hygiene and had also a sore throat 2 weeks ago. And in addition to that, the patient had elevated YTBC count and elevated C-reactive protein. And with the radiology findings, I agree with you that this patient most likely had mycotic aneurysm of the aorta. And I'll show you the latest scan done only 2 days after the CT aortic angiogram, showing basically the same findings, but measuring it, it's slightly enlarged a little bit. And the patient has been. So yeah, what do you recommend? What do you send the patient?
يعني about management stuff.
Yes, please. Yeah.
يعني أول شيء ممكن إنه يصير complication يعني يصير له rupture أو sepsis أو embolic يعني infarction فزي يعني vascular center.
Exactly. So the vascular team, the treatment will be antibiotics first, and then either it could be EVAR, endovascular aneurysmal repair, or through open surgery. And part of our scanning and analysis of the scan is to look if there is any infarctions related to emboli in the other organs. We don't see here in the kidneys, liver, or spleen. We didn't find any other manifestation.
Major branch supramesenteric يعني normal looking.
Yes, you're right. So, but most likely this patient has mycotic aneurysm. And
antibiotic يعني للintervention sent to
True. That's right. Thank you so much, Doctor. This is very appreciated. And this is our last case. Thank you so much all for your attendance. And I hope